Good afternoon, guys. Today's topic A is a healthcare system speech that I wrote. So that's today's A. Let's get going, shall we? Okay. Good afternoon. Thank you for making the time to be here. I speak to you not as an alarmist, but as a clinician and a system leader who sees the same pattern in every specialty and setting a consolation of illness that are not random but connected, driven by stress, lifestyle, and systems that no longer fit human needs. What 55 of our colleagues described to me is not a list of isolated problems. It is a single accelerating crisis that will define the next decade of care unless we act differently. The diagnosis, what we are seeing now across emergency departments, primary care clinics, pediatric practices, and long term care wards. Clinicians report a rise in the same clusters of problems. Stress driven disease, chronic stress, is manifesting as hypertension, arrhythmias, insomnia, and inflammatory illness across age groups, cardiometabolic acceleration, earlier onset hypertension, metabolic syndrome, and heart failure in younger cohorts, pediatric stimulant harms, energy drinks, toxicity, and stimulant misuse are producing cardiac neurologic emergencies in children and teens, cognitive and mental health decline, rising dementia, depression, and loneliness, especially among older adults. Functional loss and frailty, incontinence, falls, and mobility decline that erode independence and increase institutional care needs. These are not separate epidemics, they are feedback loops. Stress worsens metabolic health. Metabolic disease accelerates cognitive decline. Cognitive decline increases social isolation. Isolation deepens medical complexity. Why this matters to health systems now. The pattern changes how we must think about capacity, quality, and value. volume, and acuity will rise in ways our current models do not anticipate. Chronic conditions will present earlier that require longer, more integrated care. Care complexity will increase. The need for multidisciplinary teams, care, coordination, and community partnerships. Cost will shift from episodic procedures to long term management, caregiver supports, social determinants, interventions. Workforce strain will deepen as clinicians face more complex patients and moral distress from systems that cannot meet basic human needs. If we treat each condition in isolation, we will fail. We must redesign we must redesign around the person, not the diagnosis. 5 strategic priorities for health system leaders. Below are concrete operational priorities you can adopt now to blend the curve. Resident care models toward integration and prevention. Invest in primary care and behavioral health integration so stress, sleep, and mood are treated alongside blood pressure and glucose. Scale team based care with nurses, social workers, pharmacists, and community health workers empowered to manage chronic risk. Make social and behavioral detriments part of the medical record and care plan. Screen systematically for loneliness, food insecurity, housing instability, and stimulant use. Fund navigation and community partnerships that close the gap between clinical advice and lived reality. Protect and rebuild clinician capacity and resilience. Redesign workflows to reduce administrative burden and restore time for meaningful patient conduct. Invest in team training and mental health support for staff to reduce burnout and turnover. Create rapid pathways for early intervention and escalation. Develop outpatient rapid response teams for acute cardiometabolic events and behavioral crisis. Prevent emergency department visits and, and admissions. Use data to identify high risk patients and deploy proactive outreach before crisis occurs. Align payment and measurement with long-term outcomes. Advocate for payment models that reward preservation, functional status, and caregiver support rather than volume. Measure what matters: functional independence, cognitive trajectory, social connectedness, and clinician well-being. Implementation essentials: start small, scale scale fast, and measure continuously. Pilot integration: primary care hubs in communities with high cardiac, metabolic, and social need burdens. Create a cross functional steering group that includes clinical leaders, operations, finance, and community partners. Set 3 month, 6 month, and 12-month matrix tied to utilization, patient reported function, and staff retention. Relocate resources from low value episodic care to upstream prevention and home based supports. Closing call to action: we are at a crossroads. The illnesses our colleagues describe are the body's honest response a a world that has become too fast, too isolated, and too stimulant driven. Health systems can be part of the problem or part of the solution. We have the levers: clinical talent, data, community reach, and moral authority. Use them. Commitment today to one concrete change in your organization that aligns with the 5 priorities above. Convene your teams, fund a pilot, and measure the outcomes that matter to patient lives. If we act with urgency and humanity, we can turn this quiet, episodic into a moment of transformation where health systems restore not only health matrix, but human dignity and resilience. Thank you. Okay, guys, that is your A today. For today's A, I will be back on shortly after a break for B. Okay, so give me a little bit for a break. For now, Gator Wellness, take care, folks.